Hello, my name is Michael Andrés Perez Robles, and I'm going to talk about coronary angiography after cardiac arrest without ST segment elevation. The definition. Ischemic heart disease is a major cause of out-of-hospital cardiac arrest. The role of immediate coronary angiography and percutaneous coronary intervention (PCI) in the treatment of patients who have been successfully resuscitated after cardiac arrest in the absence of ST segment elevation and cardiac infarction (STEMI) remains uncertain. This is a short video about ischemic heart disease.
Ischemic heart disease or coronary artery disease is where we have a reduction in blood flow to the heart muscle itself. This is due to changes in the coronary vessel. Here what we can see is a coronary vessel in cross section, and we see a normal lumen of the blood vessel, therefore we'll have normal blood flow. But down here we have four forms of ischemic heart disease, starting at the least severe, moving to the most severe. Starting with the least severe or stable angina, this is where we have a fibrofatty plaque or atherosclerotic plaque that starts to build up in the blood vessel, reducing the lumen of the blood vessel, therefore reduce blood flow. This becomes most problematic when the patient is exerting themselves, such as during exercise, but the chest pain is usually relieved on rest. Because there's no damage to the heart in this form, we see no changes to cardiac enzymes, so particularly troponin is normal. ECG changes is usually also normal. We may see some changes during a stress test. Going to it unstable, the next three are actually what we call acute coronary syndrome. How unstable is different to stable is that the plaque becomes damaged and platelet aggregation starts to occur. This therefore makes the pain less predictable than stable angina, which then means pain can be felt on rest opposed to during exertion. There's still no damage to the heart muscle in this form, so the troponins are also normal. However, there will be some ECG changes, such as ST depression or T wave inversion. For the next two, these are known as myocardial infarction, which means there'll be necrosis of the heart muscle. Therefore, by definition, we will see troponin increase. The differences between these two is the ECG changes in a non-STEMI would be a ST depression or a T wave inversion most commonly, whereas ST elevation is an ST elevation. The reason for why they are different is the thrombus, which starts to build up in the blood vessel, allows some blood flow through, whereas in a STEMI, it's usually completely occluded.
Now, applications in medicine. The coronary angiography after cardiac arrest COAC trial was designed to test the hypothesis that in patients successfully resuscitated after cardiac arrest in the absence of STEMI, a strategy of immediate coronary angiography and PCI, if necessary, results in better survival compared with a strategy of coronary angiography delay until after neurologic recovery. However, no significant difference in 90-day survival was found between the two treatment groups. Patients were eligible for the trial if they had had an out-of-hospital cardiac arrest with an initial shock with and were unconscious after the return of spontaneous circulation. Patients were excluded if they had signs of STEMI on ECG in the emergency department, shock, or an obvious non-coronary cause of the arrest. Pros and cons. Pros. Survival is a patient-centered outcome, ITT analysis, sensitivity analysis, randomized control and multi-center trial. Primary outcome measure of 90-day mortality is a robust endpoint. Cons. Small population analysis may not yield results generalizable to a not large population. Trial not blind. Physicians responsible for care of patient aware of randomizations which may have influenced subsequent treatment. Data regarding patient screening obtained only in final phase of trial. It's a short video explaining the angioplasty.
Coronary angioplasty, also called as the percutaneous transluminal or balloon angioplasty, is a treatment procedure to restore the blood flow in the narrowed or blocked coronary arteries caused due to plaques or blood clots. Most coronary angioplasty procedures last between 30 minutes to 3 hours. Once the patient is admitted, his heart is monitored and is given an intravenous sedative to relax the body. A needle is inserted through the wrist into the radial artery. A guard wire is then passed through the needle and is guided through the arterial system up to the heart. A flexible catheter is slipped over the wire and threaded up to the heart. This is monitored using a continuous X-ray imaging device called fluoroscope. At this point, the guard wire is removed and the tip of catheter is positioned to enter the coronary artery. A special dye is injected which allows the fluoroscope to take X-ray images of the arterial interiors and help in identifying the position of the block. This is called angiogram. Once the blockage is identified, a flexible guard wire is inserted into the artery vessel, followed by a balloon-tipped catheter over this wire to position itself at the site of the blockage. Rapid inflation and deflation of the small balloon pushes the vessel wall out, re-establishing the flow of blood in the artery. After the blocked vessel is reopened, the deflated balloon catheter is withdrawn from the artery. The same treatment procedure is repeated in the case of multiple blockages. Most patients may also receive a coronary stent, which is a small tube made of wire mesh designed to keep the artery open once it has been treated. A collapsed stent is placed over the deflated balloon catheter as it is inserted into position. When the balloon is inflated, the stent expands and locks itself into place. The deflated balloon and catheter are withdrawn, leaving the stent behind to hold the artery open permanently. Post-treatment, a pressure bandage is applied over the radial artery to prevent bleeding. One will need to lie down for several hours, during which signs of bleeding or chest pain will be monitored. The patient may either be discharged on the same day or after an overnight stay at the hospital.
Now, issue apply in Ecuador. The mean age of presentation is 61.5 years. Male sex is the most affected in 83.6%. A vessel coronary angioplasty was performed in 38.2%, and the most frequently treated artery was the left anterior descending, with 59.91%. In Ecuador, among the findings by coronary angiography, the disease multiple generally exists more than 15% of cases. As in found in literature, a fact to highlight is that within the NSTEX, single breast disease was greater than multiple disease. Angioplasty was performed in the study in 98.1% of single breast, and of these, the one that frequency the one the procedure was anterior descending, followed by right coronary and circumflex respectively. This could be evidenced in previous records.
Sudden cardiac arrest and a heart attack are two different conditions. With a heart attack, there is a problem with the blood supply to the heart, and it leads to areas of the heart not working as well. With a cardiac arrest, there is electrical chaos in the heart, and it's usually fatal within 10 minutes. Sudden cardiac arrest accounts for almost 1,000 Americans a day losing their lives. We're very excited about these new research findings that we are presenting in this paper. At least 50% of people who will suffer a cardiac arrest have symptoms in the month before their fatal event. This is new because earlier on we had only focused on the immediate time preceding the cardiac arrest, so patients who are known to have heart disease, especially in the holiday season and New Year coming up, when we identify a peak in sudden cardiac arrests. If they have unusual symptoms of chest pain or palpitations or passing out, then they need to contact their healthcare provider. If it looks like the symptoms are dire, then the sooner you call 911, the better it will be. And this is just our first step into understanding the relationship between symptoms and future cardiac arrest.
And now the conclusion. In the COT trial, patients who underwent delayed angiography were more likely to receive salicylates or a P2Y12 inhibitor, or both, than patients who underwent immediate angiography. This observation illustrates how the result of immediate coronary angiography can influence treatment, since patients who do not have evidence of coronary artery disease on angiography do not require antiplatelet therapy. In contrast, patients in the immediate angiography group were more likely to be treated with a glycoprotein 2B or 2A inhibitor, which is more often used in the context of urgent PCI of thrombotic lesions. This difference in antiplatelet strategy between the two groups did not result in a significant difference in time in major bleeding. Thank you very much. This is all.